My job today is to talk a little bit about early intervention and the recent advancements that we've made in the field. Can you hear me okay? No. Okay. Should we turn this up? Sound? Oh, he's doing it magically back there. Okay. And I'm going to do this mainly by focusing on parent-mediated intervention designs for young children on the autism spectrum, looking at some longitudinal work we have, outcome studies using parent-mediated design, and then look into the future about what I think we have in store for us in the short and longer terms in terms of isolating active ingredients, so core components of treatment, as well as addressing all of that heterogeneity that we've been talking about throughout the day today. And this is a familiar slide, I'm sure, for all, but this is the DSM criteria for autism spectrum disorder. And what's important about this slide is that these core characteristics, the impairment in social communication and the restricted and repetitive patterns of behaviors and interests that we see in our children, as diagnostically, they present very early in development. So we have an opportunity to identify, detect the disorder early, and then of course that should lead us to interventions earlier and earlier. And in fact, we have made some great strides in early identifications of ASD, and Dr. DiPrato talked a bit about this earlier. We can see brain changes in young children under the age of 1 year, but we are able to also detect behavioral differences in young children who will go on to have a diagnosis by about 12 months of age now. And so this is much earlier than even a few years ago when we were looking at, maybe 2 to 3 years of age. Now we're looking even younger at young, early developmental trajectory. And in fact, this is just a sobering statistic for us all. The American Academy of Pediatrics obviously recommends developmental surveillance at all of these critical developmental milestones, 12 months, 18 months, 24 months of age. And unfortunately, some of the more recent work has shown that about 10% of pediatric offices are actually routinely conducting this screening, which means we have some work to do in the field to raise awareness and to get the word out for early detection. But really, why we care about this at all, early detection, is that early detection, of course, leads to earlier access to services, which we know improves outcomes. And this slide is just for effect. You need a microscope to look at all these words. But essentially, we have tons of studies that show us that one of the most robust prognostic indicators for children, their outcomes overall, is chronological age, which means the age they were identified and entered into services really matters. So we know that the younger these children are detected, the earlier they access services, the better overall their outcomes are. But then as an intervention scientist like myself thinking about developing interventions, then we need to think about, well, what are we going to do? We're going to detect these children very, very young as 12 months of age. What kinds of interventions are going to be relevant for them? And that's where we think about parent-mediated design. And this makes sense for a lot of reasons, but what we want to do is we want to partner with parents themselves, and we actually want to give them very explicit teaching in core strategies we know can affect outcome, language strategies, engagement strategies, play strategies. And the idea is that the young parent-child interaction is the most motivating context for all young children. They're most comfortable with their parents, and the parents are the most invested stakeholders we have in this treatment program. They want the best for their individual children. And the idea is we can give them strategies and specific training and in the hopes that it'll increase what we call the overall dose of intervention, which means how much intervention they get in a single day. If the parent has strategies that they value, they can take those home and they can use them throughout their daily living routines, and the idea is that should boost outcomes for our children. So I'm going to focus on 3 parent-mediated designs that have been published in the recent years. And I've selected these 3 because they're using rather rigorous research methodology. They're all using a randomized controlled trial design where children enter into the study and are randomly assigned to different types of treatments. The first I'm going to highlight is the Early Start Denver model. This intervention was a fairly comprehensive intervention, 20 hours per week of what we call ESDM versus a treatment as usual control over 2 years. So this is the most extensive intervention I'm going to highlight today. Then we have the parent-mediated communication-focused intervention out of the UK. It's called the PAC trial. This is the largest sample of toddlers. 152 of them participated. And the dose was relatively more modest, 4 hours per week of PACT versus, again, a treatment as usual for about 6 months compared to the 2 years up in Early Start Denver. And lastly, I'm going to focus on the joint attention, symbolic play, engagement, and regulation intervention developed here at UCLA. This was with 86 toddlers on the autism spectrum. And again, actually the lower dose of all 3 interventions at 1 hour per week of Jasper versus an active control condition of a parent education. So what is the evidence for parent-mediated interventions? Well, the Early Start Denver model wasn't only parent-mediated. It actually also had some therapist-delivered hours, so I want to keep that in mind. But overall, we have some longitudinal outcomes here that are fairly robust. But these are for really for cognition and adaptive functioning. So you see over the 2 years, children who received Early Start Denver model improved in their early cognition measured by the Mullen scales of early learning, and they did not see reductions in their adaptive functioning like the control group or the treatment as usual group. In the PAC trial, they ambitiously set their outcome to be reducing autism symptom severity, which is a pretty distal outcome to target through a parent-mediated design. And unfortunately, or fortunately, both treatment arms, so those who received PAC and those who had the treatment as usual, their symptom severity both decreased over time, so there wasn't a differential treatment outcome on PACT for that outcome. But they did find other important outcomes that were more proximally related, secondary outcomes like increased paternal synchrony in children, in parents who learned the parent-mediated intervention, as well as increased child initiations overall. So there were some really nice treatment effects. It just wasn't on their primary target outcome of symptom severity. And lastly, we have the Jasper intervention, and here we found treatment effects on our primary target of joint engagement that maintained at a 1-year follow-up, as well as generalized effects to a classroom teacher, and that teacher was blind to treatment status, and the assessor was also blind to treatment status. So we're finding some nice generalized effects from that. I think what's most striking is that all of these trials, although using quote-unquote similar methodology, all using a parent-mediated design, they all seem to be focused on a lot of different treatment targets. So we as a field have an opportunity to think about which types of treatments we would like to target for different outcomes. And because we're here at UCLA, I want to zoom in for a moment and talk a little bit about Jasper, which has been developed here. Jasper is a form of ABA, or Applied Behavior Analysis. It is in the group of what we call naturalistic developmental behavioral interventions. It is targeted, so it's a layered intervention that is really focused on early gesture use, language development, engagement, play, and overall, all of the children's independent initiations of all these skills. So we really, really emphasize independence and initiations over, for example, responding to a prompt. It's a modular treatment, which means you can pick it up and you can move it and you can include it in a comprehensive program, and we think it will add value to that program. And it's fairly short term. Most of our clinical trials have been anywhere between six weeks of intervention to a couple of months long. And it's backed by over 15 years of research here at UCLA under the direction of Dr. Connie Kazuri. We have other longitudinal outcomes of Jasper as well, and I like to highlight one recent publication that showed that the core components of Jasper were actually predictive of verbal ability even 4 years after receiving a single dose of the intervention, about 6 weeks, when the preschoolers were about 3 to 4 years of age. So we have a pretty robust intervention here. It's our job to disseminate it more broadly, but we're perfectionists, and you'll see, we keep testing and refining this trial. So we have some, demonstrated efficacy for these parent-mediated interventions, but what always kind of keeps me up at night is understanding how and why these interventions work, and really thinking about exploring what we believe are the active ingredients or the core components of these interventions and why they work. And 2 of the 3 studies that I highlight today have actually gone ahead and used mediation analysis to look at causal mechanisms of behavioral treatment outcomes. One of these interventions was the PAC trial, and they were really interested in understanding, well, what does relate to that increase in ADOS, or decrease, in ADOS severity score? And what they found through a mediation analysis is that a substantial majority of the variance in the ADOS score was mediated through parental synchrony, which was related to an increase in child initiations, which was related to overall increases or decreases in the ADOS severity score. So they're getting at kind of understanding what it actually looks like and what they needed to do to get those positive outcomes. In Jasper, we've done a similar mediation analysis, but this time we've looked at what we think are the core strategies of Jasper. So we distilled them down into 4 main components for this analysis, 4 strategies we think are really important. The first being environmental arrangement, how the therapist or parent sets up the environment for a successful interaction. Something we call mirrored pacing, which is really this idea of balanced turn-taking, imitation, and expansion on play ideas and themes. Communication strategies, and then prompting. So we're looking at all these strategies and really trying to get a sense of which one matters overall. And the primary outcome we were interested in this study was joint engagement, which was our primary treatment target as well. And lo and behold, what we found is that treatment, the relationship between treatment and that increase in joint engagement was really largely driven by the core strategy of mirrored pacing. This seemed to be the most important active ingredient, and in fact was explained enough of the variance where we can say it actually caused that increase in joint engagement we were seeing. So if we look at this intervention and this package, we can start to dismantle it a little bit and look at the individual strategies that directly relate to the outcomes we care about in these young children. Now, I pat myself on the back and think that's really great, and but our job is not done, because we still, I'm going to air our dirty laundry, have data that looks like this, which means that we still have a lot of heterogeneity to address in all of our treatment outcomes, and it's a theme of today. How do we address heterogeneity? And so this is one of our play outcomes, and yeah, our treatment group did a little bit better, but look at all this variability in treatment response, and how do we address all of that variability we see? And so here at UCLA, we've been thinking about methodologies that are needed to really personalize and tailor behavioral interventions to different children, and really think about for whom and why do these interventions work in maybe something that we consider more of a sequence of treatment events. So a couple of new design approaches that we're using here, and I expect to become more readily available, hopefully in the near future, in community, are comparative efficacy studies and adaptive treatment designs, one of which we're using here at UCLA called a SMART design. In these comparative efficacy trials, we have two trials right now ongoing, and what we're doing is we're not just comparing Jasper, for example, to a control or to a treatment as usual condition. We're actually trying to compare two active interventions to each other. And what we'd like to see is, are there differential effects depending on the treatment you got? And the hope or the hypothesis would be not that necessarily Jasper is always better, but that we're actually finding differential treatment effects depending on the intervention we give. So again, in our parent-mediated intervention, I already talked a bit about how the treatment group that received Jasper had these nice improvements in joint engagement and play. But what I didn't reveal yet is that active comparator, which was that parent psychoeducation, it also had its own important effect on treatment outcome. It actually decreased parental stress more. So we may have stressed our parents out by virtue of giving them all this hands-on feedback and teaching them how to use all these strategies, whereas, parents also need some therapeutics themselves. They need, some supportive information. And so it leads us to think about how we might sequence a series of treatments to really individualize for each family based on their characteristics and the child's characteristics. We have a second trial that worked in under-resourced communities in South Los Angeles that was able to replicate the joint engagement findings that we found in the first trial, but unfortunately we were not able to replicate the stress reduction part, which means that it's interesting because it suggests that maybe that psychoeducation treatment alone is not enough to reduce the stress in this low-resource community. So maybe we need to do a little more in this community to get similar types of treatment effects. So lastly, I want to end by talking a little bit about sequential multiple assignment randomized trials, which are SMART trials. We partner with people, quote unquote, much smarter than ourselves to figure out how to do these because it is quite interesting work. But essentially the idea behind this is that there's actually multiple stages of randomization, and at each stage participants are randomized. There has to be at least 2 randomizations in the sequence for it to be SMART design, and they're randomized to different ethical treatment options we think may work for that individual. And what is really cool is that later stages we can restrict the type of intervention they're randomized to. So for example, this is a trial ongoing right now at UCLA with minimally verbal individuals on the spectrum, and you can see at the beginning there's a 50-50 chance of them receiving one of the 2 treatment arms, but at later randomization points, if the child is responding and doing well, we actually have them continue the course of that treatment. It's only if they're what we deem a slow responder that we actually randomize them either to more intensity or something different. And what I think is really exciting about this really is the cutting edge right now of intervention science as we know it, and it's where the field is heading. Being able to systematically put children in a sequence of interventions and be guided as to what types of interventions work the best for different individuals. So here at the very end, at the outcome, we can say, oh, this tract actually worked overall the best for which types of individuals. I'm going to beat your 5 minutes right there because I'm almost done. So this is just an example of all the intervention research we have ongoing here at UCLA, and we're kind of exploding into a lot of different exciting work. We talked a little bit about the early at-risk study we have going on here for 12 to 21-month-olds, usually pre-diagnosis, but some had come in with a diagnosis as well. We have a lot of work using these adaptive SMART treatment designs with with minimally verbal, both preschoolers and school-age populations. We have a particular interest in working in underrepresented and lower resource community here in Los Angeles, and how do we disseminate the work that we have here at UCLA into a community that we really believe needs it the most. We have worked with other neurogenetic populations, like the ones that were discussed earlier today, TSC and Dup15q syndrome. So specific syndromes, we're also trying to figure out what are the most feasible treatment options for them. And then also even thinking about, is there added benefit to Jasper when you augment it with a medication? And so we're really trying to think about all of the different ways we can affect the lives of our families and support these children into the most optimal outcomes that we can. And so, of course, you can find us here, and if you have any questions, I'm happy to answer them. Thank you.